Open versus closed kinetic chain exercises in rehabilitation. The concept of kinetic chain exercise has received considerable attention when examining rehabilitation, particularly for lower extremity injuries. The ankle, knee, and hip joints constitute the kinetic chain for the lower extremity. Closed kinetic chain exercises, also known as CKC. When the distal segment of the lower extremity is stabilized or fixed, as is the case when the foot is weight-bearing on the ground, then the kinetic chain is said to be closed. This is used more often in rehabilitation for lower extremity conditions. Open kinetic chain exercises, also known as OKC. In an open kinetic chain, the distal segment is mobile and is not fixed. Traditionally, rehabilitation strengthening protocols have used open kinetic chain exercises, such as knee flexion and extension on knee machines. Closed kinetic chain exercises are used more in lower extremity rehabilitation, but they are also useful in upper extremity injury rehabilitation. For the most part, the upper extremity functions in an open kinetic chain, but there are also a number of activities that require a closed kinetic chain as well. It must be stressed that both the open and closed kinetic chain exercises have their place in a rehabilitation protocol. This is a picture of open and closed kinetic chains, also known as kinematic chains. In a closed kinetic chain, knee flexion is accompanied by hip flexion and ankle dorsiflexion. Knee motion in an open kinetic chain may occur with or without motion at the hip and the ankle. In the diagram, knee flexion is shown without simultaneous motion at the hip or the ankle. The concept of the kinetic chain was first proposed in the 1970s and was described by the mechanical engineers as a link system. In the link system, pin joints connected a series of overlapping, rigid segments. If both ends of this system are connected to an immovable frame, then there is no movement of either the proximal or the distal end. In a closed link system, movable segments are affected by points at which they are attached. Each moving body segment receives forces from and transfers forces to adjacent body segments, and thus either affects or is affected by the motion at those components. In a closed linked system, the movements at one joint produces predictable movements at all other joints. In a closed kinetic chain, movements of the more proximal segment occur in a predictable pattern. In the open kinetic chain, such as when the hand or foot move, movement of the proximal segment is not necessarily predictable. People often mistake closed kinetic chain to mean weight-bearing, but all weight-bearing exercises involve some element of closed kinetic chain activity, but not all closed kinetic chain activities are weight-bearing activities. Muscle activation that occurs during open kinetic chain activities is usually reversed during closed kinetic chain activities. In open kinetic chain exercise, the origin is fixed, and the muscle contraction produces movement at the insertion. In a closed kinetic chain exercise, the insertion is fixed, and the muscle acts to move the origin. Although this may be important biomechanically, physiologically, the muscle can lengthen, shorten, or remain the same length, and thus it makes little difference whether the origin or the insertion is moving in terms of the way the muscle contracts. The concept of concurrent shift applies to biarticulate muscles that have distinctive muscle actions within the kinetic chain during weight-bearing exercises. For example, in a closed kinetic chain, simultaneous hip and knee extension occur when a person stands from a seated position. To produce this movement, the rectus femoris shortens across the knee while it lengthens across the hip. Conversely, the hamstrings shorten across the hip and simultaneously lengthen across the knee. The resulting concentric and eccentric contractions at opposite ends of the muscle produce a concurrent shift. This type of contraction occurs during functional activities, including walking, stair climbing, and jumping. This cannot be isolated or reproduced by isolated open kinetic chain, knee flexion, or extension exercises. The concepts of reversibility of muscle actions and the concurrent shift are hallmarks of closed kinetic chain exercises. Some advantages and disadvantages. Let's start with the closed kinetic chain. It increases joint compressive forces, increases joint congruency and stability, decreases shear forces, decreases acceleration forces, stimulates the proprioceptors, has enhanced dynamic stability. It may be safer and produce less threatening forces. It includes co-activation and co-contraction of the muscles, and it is functional and very sport-specific. As we examine open kinetic chain, it increases acceleration forces, decreases resistance forces, increases distraction and rotational forces, increases the deformation of joints and muscle mechanoreceptors. Concentric acceleration and eccentric deceleration forces are observed. It promotes functional activity. It is often isolated to a single joint motion, and it involves strengthening and testing of the joint and the surrounding muscles. Additional comparisons. Predictable patterns of motion may be limited with closed kinetic chain activity. They are limited due to pain, swelling, muscle weakness of decreased range of motion, movement compensations. Proximal and distal joints may not always display an existing deficit. Open kinetic chain exercises allow for specific joint assessment. Closed chain activities rely on more complex series of muscle contractions, such as the agonist or antagonist contraction. Proprioception, joint position sense, and kinesthesia are critical to the neuromuscular control of body segments within a kinetic chain. To perform a motor skill, muscular forces occurring at the correct movement and magnitude interact to move the body parts in a coordinated manner. Coordinated movement is controlled by the central nervous system that integrates input from joint and muscle mechanoreceptors, acting within the kinetic chain. Smooth, coordinated movements require consistent integration of receptor, feedback, and control center information. In the lower extremity, a functional weight-bearing activity requires the muscle and joints to work in synchrony and in synergy with one another. For example, taking a single step requires concentric, eccentric, and isometric muscle contractions to produce supination and pronation in the foot. Ankle dorsiflexion and plantar flexion, knee flexion, extension, and rotation, and hip flexion, extension, and rotation. The lack of normal motion secondary to injury in one joint will affect the way other joints or segments move. To perform this single step in a coordinated manner, all of the joints and muscles must work together. Thus, exercise that acts to integrate rather than isolate all of these functioning elements would seem to be the most appropriate. Closed kinetic chain exercises, which recruit foot, ankle, knee, and hip muscles in a manner that reproduce normal loading and movement forces in all of the joints within the kinetic chain, are like functional mechanics and would appear most useful. Quite often, the open kinetic chain exercises are used primarily to develop muscular strength, while little attention is given to the importance of including exercises that re-establishes proprioception and joint position sense. Closed kinetic chain activities facilitate the integration of proprioceptive feedback coming from Pacinian corpuscles, Golgi tendon organs, and Golgi ligament endings throughout the functional use of multi-joint and multiplanar movements. Open and closed kinetic chain exercises have different biomechanical effects on the joint of the lower extremity. Walking along with the ability to change direction requires coordinated joint motion and a complex series of well-timed muscle activations. Biomechanically, shock absorption, foot flexibility, foot stabilization, acceleration and deceleration, multiplanar motion, and joint stabilization must all occur in each of the joints in the lower extremity for normal function. Understanding how these biomechanical events occur during both open and closed kinetic chain activities is essential for clinicians creating the rehabilitation protocol. Open kinetic chain exercises for lower extremity strengthening have been used. This practice was partly the result of designing constraints of existing resistive exercise machines. The current popularity of closed kinetic chain exercises can be attributed primarily to a better understanding of kinesiology and biomechanics, as well as neuromuscular control factors involved in the rehabilitation of lower extremity injuries. The current literature provides a great deal of support for accelerated rehabilitation programs that recommend the extensive use of closed kinetic chain exercises. Several different closed kinetic chain exercises have gained popularity and have been incorporated into rehabilitation protocols. Among these exercises commonly used are the mini squat, wall slides, lunges, the leg press, stair climbing machines, lateral step-ups, terminal knee extensions using tubing, stationary bicycles, sliding boards, biomechanical ankle platform systems, also known as BAPS boards, and the fitter. Although closed kinetic chain exercises are most often used to rehabilitate lower extremity injuries, there are many injury situations where closed kinetic chain exercises should be incorporated into the upper extremity rehabilitation protocol. Unlike the lower extremity, the upper extremity most often functions as an open kinetic chain system. Most activities involve movement of the upper extremity in which the hand moves freely. These activities are generally dynamic movements. In these movements, the proximal segment of the kinetic chain is used for stabilization, while the distal segments have a high degree of mobility. Push-ups, chinning exercises, and handstands are all exercises in gymnastics, and they would be examples of closed kinetic chain activities of the upper extremity. In these cases, the hand is stabilized, and the muscular contractions around more proximal segments, the elbow and the shoulder, function to raise and lower the body. For the most part in rehabilitation, closed kinetic chain exercises are used primarily for strengthening and establishing neuromuscular control of these muscles that act to stabilize the shoulder girdle. The scapular stabilizers and the rotator cuff muscles function to co-contract and allow them to provide a stable base for both mobile and dynamic movements that occur in the distal segments. Although traditional rehabilitation programs concentrate on treating and identifying the involved structure, the body does not operate in isolated segments, but instead works as a dynamic structure. We can use the open kinetic chain system in the latter stages of rehabilitation to train the endurance of the glenohumeral and scapulothoracic musculature.